Ashton.
My lady, please may I call Alwyn Jones?
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
I hope you were warned that we wouldn't get to you this afternoon. I hope you're not waiting too long.
That's fine, thank you.
Could you please tell us your full name?
My name is Mr. Alwyn Jones.
And thank you for your witness statement for Module 6, dated the 17th of December 2024. You are the immediate past president of the Association of Directors of Social Services, Cymru. Is that correct?
Yes, I mean there is a new president now, so there's been a further president since we came to this stage, so yes.
Thank you. And I will refer to it as ADS Cymru throughout.
ADSS Cymru, yeah.
Your substantive role is as Chief Officer of Social Care for Wrexham County Borough Council, is that right?
Yes, that's correct.
And in respect of ADS Cymru, you took up role as President in December 2022.
That's correct.
And your term of office ended in March 2024, is that correct?
That's correct.
And I understand that you have some preliminary remarks that you would wish to make today.
Yes, if that's okay. On behalf of ADSS Cymru, I would just like to note our sincerest condolences to any families that were affected by bereavement during the pandemic, and commit to doing all we can in terms of supporting understanding. Ar ran ADSS Cymru, hoffwn nodi ein cydymdeimlad dwys ar ran I bob un teulu a ddioddef oedd colled yn ystod y pandemic, a wnawn ni'n goreidio helpu o ran y dysgu yn symud ymlaen. Diolch. Thank you.
Thank you. ADSS Cymru is the National Professional Leadership Organisation for Social Services in Wales, is that correct?
Yes, that's correct.
And my understanding is that it represents the collective view of all 22 local authorities' social services departments, is that right?
Yes, that's correct.
And the aims of the organisation are to ensure that adults, as well as children in need, experience well-being and achieve what matters to them by accessing the right care and support, is that right?
Yes, that's correct.
And just to confirm, in Wales, adult social care and children's social care are sort of dealt with by one person, essentially.
Yes, generally there is a director for social care who covers both adult and children's services.
Thank you. And speaking of that, it's a statutory appointment in each of the 22 local authorities. And my understanding is that it is responsible, directors of social services are responsible for services quality and driving delivery of improved outcomes, safeguarding, service and performance management, etc. Is that right?
Yes.
In terms of the role of ADSS Cymru during the pandemic, I understand that you worked closely with the Welsh Government and other stakeholders, and you also were involved in communication, for example, disseminating key messages to stakeholders and other matters. Is that right?
Yes, we did play that role.
I'm going to ask you some questions about pre-pandemic capacity of the adult social care sector in Wales, and in particular resilience. If I could pull up your witness statement on screen, please. That's INQ 333528094, page 20, paragraph 3.13. In your statement, you mentioned that issues about the resilience of the independent care sector also surfaced. Unlike England, Wales has few large care home chains where staff can be redeployed between homes. Many are family-owned, and their capacity to manage during the pandemic was severely limited. Some local authorities did what they could to help. For example, in one area, the local authority's catering department provided cooked food for residents of an independent care home because the home's catering staff were absent due to illness. In terms of Wales having few large care homes compared to England, how did that affect care homes in practice during the pandemic?
I think how that affected care homes during the course of the pandemic is they had smaller units in terms of resilience, in terms of being able to depend upon during periods of staff sickness, isolation, they also had different sorts of models in terms of the buildings that they operated from. Generally, they were from different type of buildings, generally older buildings that had become care homes. So I think it made them less resilient in terms of that ability to move staff, and that they had very little additional capacity to move into.
How would you describe the level of consultation with the Welsh Government on the adult social care sector during the pandemic?
During the course of the pandemic, we had regular consultation with Welsh Government during the course of the pandemic, very, very strongly in early days. And then depending upon the stage of the pandemic, it would vary depending upon the level of intensity in terms of lockdown decisions made at Welsh Government level. But certainly in the early days, we had very regular meetings weekly, and some colleagues were meeting more than once a week. We had directors' meetings, which then fed into those meetings with Welsh Government, and we were involved in a number of key groups.
And from paragraph 2.20 of your witness statement, my understanding is that the first prime contact that ADSS Cymru had with the Welsh Government about the pandemic was in February 2020. And that was a meeting with Albert Heaney and Sue Cooper, who was the then president of ADS Cymru. Do you think that was the right time in terms of communication with the Welsh Government about the adult social care sector, or do you think it should have happened sooner?
It's difficult for me to comment in terms of the science of the pandemic. Clearly, sooner rather than later would have been the best. Clearly, that's the first opportunity Welsh Government felt they had to start having that conversation about the pandemic with us, and obviously the level of seriousness with which it was being considered.
In your witness statement, you described the social care sector as the Cinderella service, like several other witnesses that we've had for this module. You mentioned discharge and lack of medical support in care homes as an example of how it was shown to be the Cinderella service during the pandemic. Are there any other ways in which you think the NHS was prioritised over the adult social care sector in key decisions by the Welsh Government during the pandemic?
I think consideration of social care in the context of a number of decisions was always later in the NHS. So when discharge was considered, it was clearly considered initially with a focus upon supporting the NHS and having a platform within which they could cope with the pandemic. Similar areas around when decisions were made around testing, decisions were made around protective equipment. It always felt that actually social care was considered slightly later. It was considered, but it was not immediate. It felt like the initial narrative was around the challenge within the NHS.
On the discharge of residents from hospitals to care homes, ADS Cymru were consulted on the discharge guidance at the beginning of April 2020. And I presume that the decision to discharge without testing had already been made by the Welsh Government at the point where ADS Cymru were consulted. Is that right?
I mean, I think there was some there was a period of time where there was not clarity around the testing and discharging. Clearly, the guidance referred to needing to be tested prior to discharge. So yes, it would have been better to have immediate consultation in that regard.
And in your statement, you set out the overall view of ADSS Cymru, which was that discharge without testing was irresponsible. At the time, at the beginning of the pandemic, as I'm sure you're aware, there was a lack of testing capacity then. Do you think that in a future pandemic, there should only be discharge into care homes after a negative COVID test, or if there is a positive COVID test, that the person be put in step-down facilities before being discharged into care homes?
Clearly, in the case of COVID, and given the restrictions that was put on society, clearly the natural place to take this to is that there should have been testing prior to discharge. I can't comment on the nature of a future pandemic because it could well be a very different nature to COVID. But in terms of the pandemic which we faced, should there have been negative testing prior to discharge? My answer simply is yes.
And what about testing before discharge for people who are going to be discharged back into their own homes in need of domiciliary care or care by unpaid carers? Do you think the need for a negative test before discharge is perhaps maybe slightly less acute than in care homes?
I think there needed to be testing. I think potentially, as long as domiciliary care agencies had the required protective equipment to support their staff, and we have to recognise that maybe it could have been slightly different. But clearly there are lots of conditions that needed to be in place for that to be different at all. Clearly in a care home, it's in a restricted environment with lots of other people around. And actually, I think it was important that there were negative tests.
If you had a shortage of tests, forgive my interrupting, if you had a shortage of tests and therefore couldn't test before discharge and you had to, or you had decided you had to make space in hospitals, is the alternative to ensure that anyone discharged is put into isolation in their own room or in special isolation facilities?
Would that have been the ideal?
Yeah.
Yes, I think it would have been, but it does make the assumptions about care homes having the right protective equipment in terms of supporting them. But yes, agreed.
So it's not just isolation, it would have to be on the basis there was PPE as well?
Correct.
Right.
Because I think you put staff in a very difficult position in terms of caring should you not have that PPE in place.
Then the staff get infected.
Correct.
Circle of infection, right. Thank you.
Correct.
In your statement, you've mentioned various issues in respect of discharges that did not take place in a manner in which it was in conformity with the guidance. If I could just bring up your statement on the screen, that's INQ 000528-094, page 22, paragraph 4.6, please. You've stated that concerns, this is the middle of the paragraph, concerns for the health and well-being of existing residents and staff meant that many directors were not prepared to sanction discharges without testing. This resulted in tension and confrontation, and in many parts of Wales, a significant breakdown of trust between care homes and hospitals. The situation was exacerbated by the delay in the Welsh Government publishing its discharge guidance, which was some 2 weeks after the UK published its guidance for England. What was the role of directors of social services in sanctioning discharges during the pandemic?
I think what you'll find is that directors of social services, through their commissioning teams, have quite a good relationship with care homes. And where there was concern around admissions either being expected from residential homes, they drew in the director of social services in terms of that conversations, and directors of social services gave that clear guidance: no discharges without a negative test.
Is this a role that exists like prior to the pandemic? So, for example, would directors of social services be involved in the decision of discharge or not discharge?
On an ongoing day-by-day basis today, is that happening? No, but obviously were there to be an outbreak of diarrhoea and vomiting within a hospital ward or some issue, they may be drawn into things where things become acutely difficult in terms of those discharges coming out. So on an operational day-to-day basis, not ordinarily a director of social services is not involved in that, but they will be drawn in where there are acute problems.
If I could turn to page 32 of your witness statements, that's INQ 000528-094. You give an example of an issue with discharges in this part of your witness statement. You state that the overwhelming focus on protecting the NHS did, on occasions, dismiss any notion of safety and well-being of staff and residents in adult social care. For example, a doctor in an emergency department sending a patient to a residential care home without testing for COVID-19 and demanding the homes take them. This resulted in a heated argument with directors of social services who backed the home's refusal to take a person into care. How common or widespread was this issue at the beginning of the pandemic?
I think in the early days of the pandemic, it was reasonably common. Once the discharge guidance came out, it was less common, although still happened at periods of high pressure. There are a number of anecdotal examples here. There are others which are not listed here as well. So in terms of beyond when the discharge guidance, I say it was significantly less common, but still happened on occasion.
We're going to look at another one of the examples, which is in a witness statement, in an email. Can I pull up INQ 000 511 731, page 1, please? This is an email from a director of social services stating that Swansea has experienced discharge to dom care where we weren't informed that a patient had been tested. Subsequent result of test was positive, was back before we had much of a grip on PPE, risked infection of a number of staff and other care recipients. 8 staff ended up in isolation. Do you think that there was a widespread issue of discharge without testing into domiciliary care?
In the same regard, early in the pandemic, yes, I think there was.
Do you think that issue of discharge without testing into domiciliary care was adequately considered during the pandemic?
I think actually early in the pandemic, the health partners tended to see residential care as the main area of discharge, and therefore the wider economy of care was not considered adequately. No, there was a perception that you had hospitals and you had care homes, and that wider economy, which is large in terms of the amount of people we deliver care for in the community, was not adequately considered, no.
And just sticking on this email, point 2, patient discharged to a care home were tested as positive, not symptomatic. Care home weren't aware until after the individual died, and GP turned up in spacesuit saying that they could see on the records that the individual was positive for COVID infection. Was there a widespread issue of care homes not being told of the COVID status of the person discharged?
I think, again, we go back to the earlier stages of the pandemic. Prior to some of the discharge guidance coming out, it became significantly less frequent after that point.
And there is another example I wanted to pull up on screen. It's INQ 000 511 732, page 2. This is from another local authority, where it says, please advise, we have received a referral of a gentleman where the home was not willing to accept them back as no COVID status was confirmed. However, it seems following various calls to the ward, the Home and Social Services, that regardless of the results, they were unable to carry out the 14 days isolation precautions post-discharge within the home, as the gentleman is cognitively impaired and walks about, and they do not have the staffing to carry out one-to-one, as they do not want to bring in agency cover. And then underneath, there's another example. I have now received a call from ED about another resident from the same home admitted today due to not eating and drinking. Prior to today, they had been somewhere and had since tested COVID positive. All tests carried out in ED today, i.e. chest x-ray and bloods, are normal. I've been informed she has taken fluids for them without concern and there's no clinical reason to stay in hospital. Again, this patient has cognitive impairment and is wandering. The home has refused to have this resident back as well. Do you think consideration of residents who are cognitively impaired and the ability to implement IPC measures on discharge was adequately considered by the Welsh Government during the pandemic?
No, I don't think it was. I think we were ill prepared for individuals such as those two noted here because the nature of the care homes and the fact that there were not good isolation facilities within those care homes for individuals such as these.
And in your statement, I'm not going to ask to pull it up on screen, okay. You mentioned that there were instances of health boards trying to use what might be termed technicalities to bend or to work around the rules. For example, a care home resident taken into hospital might have spent time, often a lengthy period, such as overnight, in a hospital assessment unit, as opposed to being admitted to a ward. The hospital then insisted that as the person had technically not been admitted, they should be able to return to their care home without isolation and without the use of a step-down facility. There was also seemed to be inconsistencies between some hospitals with different timescales applied. How often did this occur? Hospitals using technicalities, as it were?
how often did it occur? I think there were instances in every council across Wales. They were not regular, but it did happen in most areas of Wales.
On the 29th of April 2020, the Welsh Government issued updated guidance on the step-up and step-down care arrangements during COVID. In it, they described two options as regards to discharge. The first being discharge back to an existing placement or care package where the individual has received a negative COVID-19 test prior to discharge, or a step down or step up within a designated NHS facility where an individual has received a positive test for COVID-19 prior to discharge, are still symptomatic or within the 14-day initial isolation period. What are your views on how useful the step up, step down arrangements were in Wales?
I think in practice, listen, they're useful to give guidance. I think you refer there to the second option of a specific step-down facility. I think in practice, very few of those came into being in Wales. So the idea of the Nightingale wards were floated in all areas of the country and a couple of locations agreed upon. I don't believe they were significantly used. And I think that was partially because there was not enough resilience in terms of the staffing required to do that. And so I don't believe that happened to a great extent.
So just to clarify, do you think it's more of there's a lack of staff rather than a lack of need?
I would say in terms of those sort of Nightingale facilities, yes, it would have been very difficult to staff them.
Now, in England, the UK government created a designated settings policy where local authorities had to list care homes that were capable of taking on COVID-positive residents before moving them into their facility or home that they ordinarily live in.
I'm sorry, I missed that last bit.
So that they ordinarily would live in terms of designated settings. It's like a step-down sort of facility, but it's in respect of care homes. Seeing as you've stated that the step-down facilities weren't really used that much in Wales, do you think a similar policy like designated settings would be useful in Wales, or do you think the step-down would be sufficient in a future pandemic?
No, I think they would be useful in Wales so long as we've considered how we staff and resource them in terms of them being able to be practical. I think as a concept and an idea, it's really, really good. There does have to be some practicality to it around how we staff, how we make sure that they actually work.
And in terms of pre-pandemic planning, do you think that this is something that should be considered?
Yes, I do.
In terms of visiting restrictions, I'm going to pull up your witness statement on screen again. It's INQ 000528094, page 24, paragraph 4.13. And in it, you state that there were some inconsistencies in visiting restrictions across Wales because of questions about the guidance, differences in local interpretation and application, and who was responsible for decision-making. And you state, for example, the managers of care homes asking for advice on what they should do, whereas the responsible individual, it was their responsibility to decide. We heard evidence from the Older People's Commissioner for Wales, who also mentioned difficulties when it comes to visiting restrictions because of a lack of understanding of who was responsible for decision making. Who do you think should be responsible for decision making when it comes to visiting restrictions in a future pandemic?
My general view here is there should be some general principles that should sit above this in terms of end of life and ability to see your relative. And I think then, depending on the local situation, ultimately the care home and a registered individual has that responsibility. However, I would see us as local authorities and local partners being able to give some guidance in terms of actually what is our view around, for example, in Wrexham, what is the current position in terms of spread, what's our current view in terms of, and collectively that is agreed. So I think there should be some general principles nationally with some local interpretation based upon the situation going on.
Now, I understand it from some evidence from the inquiry. There were some blanket bans imposed in Wales on visiting restrictions by incident management teams, which went against government guidance. How do you think this could be improved in a future pandemic?
I think the way that could be improved in the future pandemic is having good solutions for how people can visit safely. There are examples, I think, within my statement of where summer homes had particular arrangements to meet outside, specific ways of doing that. I think what we need to do is define what is a safe area to meet so that even in the worst of circumstances, a person who's in a care home can have contact with their family and friends in a way that is safe.
We heard evidence from Albert Heaney for Module 6, where he had been asked about there being at least 2 local authorities who had imposed bans on visits without the incident management team input or any input at all. And he was asked whether he was written to local authorities, and he said he did, to make it very clear what was supposed to happen. In your view, do you think if there are going to be any local decisions in respect of visiting bans, let's say because there's an outbreak in a local area, do you think that incident management teams are the ones that should be the ones making the decision?
Yeah, I think working alongside the care home. Ultimately, the care home, the registered individual has to have a role, because I suspect their insurance says they have to have a very key role in it, but I think they should be advised by the local incident management team, yes.
On PPE, you said in your statement, which I'm not going to pull up on screen,
Okay.
Initially there appeared to be questions whether care homes should have PPE, as well as care homes are not hospitals. Who was making that question? Was it Welsh Government? Was it Public Health Wales?
I think that question emanated from the fact that there were poor supplies at first, and somewhere in the order of priority, care homes were not quite as high a priority as the NHS. So I'm not sure that was ever verbalised or officially said, but it was something that was the feeling that we had, those of us who were linking in with care homes, that they were not given the same level of priority.
If we could pull up an email exchange, INQ 000511730, page 1. I think this is where examples of issues when it comes to discharge were asked about. The clearest cut example is someone who was discharged from hospital, no PPE, became ill and was readmitted a few days later and then found to have COVID-19. Even when the diagnosis came through, it took a couple of days to provide PPE. More generally, the issue is that people are discharged to care homes untested. It's not clear if they have the virus or not. Do you think that in a future pandemic, PPE should be one of the main focuses in ensuring that care homes have PPE before discharges take place?
Yes, I think it should be one of the main focuses.
In Albert Heaney's evidence, he was asked a question about PPE shortages, and in answer he said there was always enough PPE in the system. Do you agree with that?
In the early period of the pandemic, no, I don't entirely agree with that. The situation did become better, and Welsh Government supported us significantly, and supplies were passed down to local authorities to pass to their providers. But in the early period of the pandemic, no, I recall being in Anglesey at the start of the pandemic when we were doing everything we possibly could to source PPE, and it simply was not available. So, no, I wouldn't agree that there was sufficient PPE initially.
In your witness statement, I won't put it up on screen, but paragraph 6.174, there was an email that you'd mentioned from the Welsh Government about an issue reported by an independent care home in Cardiff, where existing PPE suppliers appeared to be restricted supplies to providers in England. And there's questions about actions done by Public Health Wales. Was it a common occurrence that there were providers of PPE that decided to restrict their PPE provision to other nations other than Wales?
I think it was clear at first that there was a priority being associated with providing certain sectors with PPE, yes.
In terms of PPE and unpaid carers, what, if anything, did ADSS Cymru do to support unpaid carers and access PPE?
My recollection, this isn't significant, but I do think that we did make PPE available to unpaid carers in due course.
Do you think they have enough data in Wales on unpaid carers to be able to ensure that they receive PPE in a future pandemic?
No, I think our data about unpaid carers needs to be strengthened.
Do you have any ideas of how that could be strengthened?
I think there are efforts being made for people to self-register as carers, and I know that Carers Wales are making efforts to increase that awareness of carers as why it's important to register as a carer. But I think there are still some people who prefer to remain private as carers, and obviously in a period like a pandemic, that makes it more difficult, does it not?
I just want to see if you can help me with this. Testing was initially not very widely available for the adult social care sector, but then it became available to social care staff, and there was a scheme developed between the Welsh Government, the WLGA, Ads Cymru and Data Cymru for local authorities to identify 15 members of staff per council to be tested. Are you familiar with that scheme?
Yeah, I think when we say from the council, I think we mean from the council services, probably care homes and domiciliary care, if I've got that correct. They weren't just local authority staff, were they?
No. In terms of that scheme, we heard from the WLGA that it covered both local authority social care staff and staff employed by commissioned providers. What about providers that were not commissioned by local authorities? Do you know how they maybe had access to testing at that point?
I don't know, no.
In a future pandemic where there are limited, let's assume there are limited numbers of tests for whatever the pathogen is at the beginning, do you have any recommendations on how testing in the adult social care sector could be implemented?
I think however limited there are, those tests do need to be made available. And I guess we need to co-produce how we're actually going to prioritise who receives those tests, and that there at least is that early dialogue around actually how do we work within this limited number of tests.
And my final question on this point, from the WLGA, we had heard that the process of identifying social care staff able to be tested was complex and time-consuming during that 15 members of staff per day period. I understand that there is currently now a register for adult social care workers held by Social Care Wales. Do you think that would assist in terms of identifying social care staff in a future pandemic?
I think it would, and it will also help in terms of records as to who has been tested, yes.
In your statement, you state that when testing became available to social care, the focus was on care home staff and that there was concern about a lack of access to testing for domiciliary care workers. Do you think, in a time there may be a shortage of testing, priority should be given to care homes? Or do you think it should be looked at differently?
I think it probably needs to be looked at differently, and we need to consider how the priority works across both care homes and domiciliary care as well. Listen, I mean, also in terms of social care, it's not just domiciliary care. We've also got a network of people who go out to see people within social care, both visiting, we have staff within supported living environments, others. So I think there needs to be an exercise to prioritise across the sector.
May I pull up the Care Forum Wales I don't need to pull up the statement, actually. I'm going to just read it instead because it'll be
Okay.
quicker. We've heard evidence in the inquiry of issues in respect of funding provided to care providers in order to cover the costs, the associated costs of the COVID-19 pandemic. We've heard from Care Forum Wales in their witness statement that there were issues in respect of the funding going to care providers, that there was a lot of delay in it reaching the sector. Do you think that there's anything that could be done to rectify this in a future pandemic?
Yeah, I think probably some relaxation of the, I guess, being able to provide money in advance to support care homes while they're right in the crux of the financial difficulties, with some accounting which happens afterwards, would probably make it easier in terms of passing those funds down. We as a local authority, we obviously have to have an audit trail in terms of this is where we're passing it to, this is the evidence in terms of actually that provision. I think I would suggest some relaxation of that would make things easier, yes.
Do you think that the additional funding should be paid directly from the Welsh Government to care providers, or do you think it should still be funnelled through local authorities in the future pandemic?
I think the reasoning behind funneling through local authorities is the nature of provision in every local authority is different. So the nature of provision, whether it's across the independent sector, voluntary sector, the nature of the care home provision and the domiciliary care is different. And in actual fact, that allows local authorities to target it to the correct places. I don't deny, though, that it maybe shouldn't be done. We should ensure that it goes faster.
In terms of data, we've heard evidence that there was insufficient data on matters for the pandemic, but just to focus on ethnic minority groups, you stated in your statement that there was insufficient data on transmission and mortality rates for ethnic minority groups and other protected characteristics. When you were referring to that, were you referring to recipients of care, care staff, or both?
I think both, and the population more generally as well.
Has the situation improved to date in respect of data?
I'm not sure is the answer to that. I'm not sure.
If it hasn't, do you think that's a potential work programme that
Yes.
the Welsh Government should consider?
Absolutely. Where there are vulnerabilities for particular parts of society, we need to make sure we've got good data all round.
In terms of the changes to the regulatory inspection regime, and in particular Care Inspectorate Wales' decision to pause routine inspections, at paragraph 9.1 of your statement, you state that you think the decision to pause routine inspections of registered social care providers was appropriate. Now, as you're aware, at certain points in the pandemic, especially when there were outbreaks, etc., care homes almost became what people call closed institutions. There was no visitors from loved ones, hardly any visits from other professionals, so for example, medical staff or social workers. And then now, no routine inspections by Care Inspectorate Wales. What about safeguarding for residents in care homes? Were there any concerns about safeguarding for them?
Okay. Clearly that level of inspection means that there was less oversight in terms of safeguarding. I think it's really important to note, though, that safeguarding structures within local authorities continue to work, meaning if we did receive concerns, whether that be from a staff member or others around safeguarding within a particular establishment, we did make inquiries. We did work with a care home to address whether there'd been a safeguarding issue, and those things continued to happen. So whilst oversight will have been less, I do inherently believe in that actually most staff go into care for the right reasons, and if they observe anything that they have concerns around from a safeguarding perspective, they do and will report that, and we then still have the structures in place to actually investigate and do work. So was it less? Was there less oversight? Yes. Was there still a level of oversight and support in the events of safeguarding concerns? Yes, there was.
just going to put up your statement in respect of the impact of the pandemic on unpaid carers. It's INQ 000528094, page 69. Thank you. As I understand it, Advocacy conducted their own research into the COVID-19 experience for unpaid carers in a study commissioned by the Welsh Government. And the findings captured the lived experiences of unpaid carers during the pandemic. And if we turn to the next page, we have a list of harms that unpaid carers had said they faced. Social isolation and loneliness, mental health concerns, financial and economic impacts, deterioration in conditions on the care for people, and other matters as well, including delays in assessments. What did Advocacy or local authorities do to alleviate the impact of the pandemic on underpaid carers?
On an individual basis, we tended to work with our voluntary sector in terms of how they could support unpaid carers, whether that be through getting them medications, supporting them in terms of getting food. And that was the main actions we took, liaise with the voluntary sector in terms of that work.
Thank you. And a final point that I just wanted to ask you some questions about is pre-pandemic planning. In respect of local authorities in Wales, and just the Welsh methods generally on planning, who's responsible for plans in the event of a pandemic?
Ultimately, I think the responsibility should lie with Welsh Government, but then devolve down to local authorities and local health boards in terms of individual plans, in terms of responses. Clearly, that overall strategic needs to come from Welsh Government. Then the operational practice that we need to put in place is by those very key institutions of health and local authorities.
And currently, is there any requirement for care providers in Wales to have pandemic plans?
I believe they do have to have business continuity plans. How specific that is about pandemics, I'm not sure.
Do you know if they are reviewed by anybody?
Yes, CIW and our contracts teams would go in and review any business continuity type plans that care homes have.
And plans for local authorities, are they reviewed by the Care Inspectorate of Wales as well?
Yes, we do get reviewed by Care Inspectorate Wales. I can't remember them focusing on those, but yes, Care Inspectorate Wales do review the business continuity plans we have in place for services.
My lady, those are my questions.
Thank you very much, Mr. Day. It's now Mr. Stanton, who is that away.
Okay.
Thank you, Melanie. Good afternoon, Mr. Jones.
Good afternoon.
I asked questions on behalf of the COVID-19 Bereaved Families for Justice Cymru. I just have two topics to cover with you. The first relates to the issue of PPE. And at paragraph 6.15 of your statement, you refer to a letter that ADSS Cymru sent to the Welsh Government on the 31st of March 2020, which raised a number of concerns, one of which was that the PPE guidance for the social care sector was tailored to supply constraints rather than the risks to staff and vulnerable people. And I should say the client I represent shares the view expressed in that letter. Please, could you explain and expand on the particular aspects of the guidance that you say was tailored to supply considerations rather than safety?
I think in looking specifically at it, I'm not sure I can, but the overall feeling that local authorities had was that the level of PPE that was being diverted towards the care home sector was insufficient towards the start of the pandemic, and that clearly our calls to Welsh Government was to address that. Caring for an individual who had COVID in a care home was actually not that much different to caring for them in a hospital. And actually in some care homes, they were in more difficult environments where maybe infection control, space was at a premium, and therefore the overall view was that it didn't cater sufficiently for that.
You may not be able to answer this question,
Okay.
but could I ask, were your concerns around the quantity of PPE, or was it more around the type and adequacy of the PPE being provided?
Certainly in the early stages, some of the PPE was not adequate. As supplies got better as time passed, that became less of an issue. We do refer in the statement to a couple of examples. Well, there were some issues with quality. Over time, that became better.
Thank you. My next topic concerns testing on discharge. You dealt with that already at length in your evidence. But my question concerns the situation in December 2020.
Yeah.
At paragraph 4.28 of your statement, you refer to the Welsh Government's changes to hospital discharge guidance, which included the ability to discharge patients who were testing positive, albeit at a low level.
Yeah.
And you set out the concerns of some of your members in connection with this change, including that the guidance was written purely from a hospital discharge perspective and did not reference the risk for the care homes. Immediately following this change in January 2021, there was an alarming increase in COVID-19 infections and, sadly, deaths in care homes in Wales. At this point, were you able to revisit the concerns that you'd expressed in December? And if so, are you able to indicate the response from the Welsh Government?
I don't think we did particularly revisit. It was seen that the science was indicating that there needed to be a change in the discharge, and I don't believe we did revisit them significantly, no.
Thank you. Thank you, my lady.
Thank you, Mr Stanton. And then it's Miss Jones, who's that way.
Thank you, my lady. Good afternoon, Mr Jones. I ask questions on behalf of John's campaign, the Patients Association and Care Rights UK. My first question, in fact, is on the same topic that Mr Stanton was just asking you about, your observation that the guidance on hospital discharge was written purely from the hospital perspective, that it did not reference the risks for the care homes and residents. And in fact, this earlier in response to a question from counsel to the inquiry, you said that the hospital discharge policy was an example of the NHS being prioritised over social care. In respect of that, do you agree that the government's failure to take account of the risks of the hospital discharge policy on adult social care settings could have been avoided if you or other key stakeholders had been consulted about that policy before it was introduced?
Yeah, I think we could have minimised the risks, yes.
Thank you. My next question is about the problems with data relating to the adult social care sector, problems which you identified and talked about in your statement. For example, that the data on registered care settings in Wales held by the Office for National Statistics is woefully out of step with data held by Care Inspectorate Wales. And you also talked earlier today about the need for data on unpaid carers to be strengthened. Do you agree that it would be helpful in this regard for a centralised database of care sector data to be established, which could be accessed to support understanding of the care sector and inform decisions that are made about it?
I think that would be really good. I think, obviously, you'd have lots of sources coming into that central database, but I think one central database would be really, really valuable and useful, yes.
Thank you. Then my last question, at paragraph 4.10 of your witness statement, you say that the Welsh Government shared its thinking with ADSS Cymru in advance of lockdowns, but that care recipients and care workers heard about them when the public announcements were made. Do you agree it would have been helpful for those two cohorts, care recipients and care workers, or the stakeholder groups that represent their interests, to have also been consulted or given advance notice of such decisions?
I think it would have been helpful. I think it would have had to be done in a managed way so that any spreading a message wider to the public was managed. But yes, I do think it would have been helpful to have that level of consultation, yes.
Thank you very much, Mr Jones. Those are all my questions.
Thank you, Ms Jones. That completes the questions we have for you. Thank you very much indeed for your help. We're really grateful. I appreciate with all your other responsibilities. It's you said you had 2 successors since you. Is it a year or 2-year leave?
No,
post?
we tend to do a year as the president of ADSS. So I think I finished in 2024. There was one person 24, 25, and there's one person now. So I am 2 back.
So you've got to go back to your day job.
Yes, indeed.
Which you were doing anyway, I'm sure, at the same time as
Yes.
running the association. Thank you very much indeed for your help. I'm really grateful. And safe journey back to Wales.
Thank you.
I've been asked if we could break now before the next witness, because I think council may be meeting the witness. So if I return at quarter to or 10 to, let me know. Let's say 10 to. Thank you. Sorry for the... Mr. Beach.
Yes, good afternoon, my lady. Thank you for your forbearance. Please may we call Mr. Eddie Lynch.
I swear by Almighty God that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you for coming back to help, Mr. Lynch.
You're welcome.
Coming here to help, as opposed to asking.
Yes, thank you. Good afternoon, Mr. Lynch. I'm going to ask you some questions today arising out of your witness statement, which is dated the 17th of February 2025. And for everyone's reference, that's INQ 000474926. You took up your role as Commissioner for Older People for Northern Ireland on the 13th of June 2016, being appointed for an initial 4 years, and were subsequently reappointed for another 4-year term on the 13th of June 2020, and then filled that role in a caretaker capacity until 12th of December 2024 before moving on to pastures new. Is that correct?
That's correct, yes.
And the inquiry is familiar with the role of the office, but just very briefly, the Commissioner is an independent statutory role set up under legislation from 2011. And you set out at paragraph 11 of your witness statement that the Act affords me promotional, advisory, educational and general investigatory powers and duties. Their purpose is to enable me to champion the rights and interests of older people in Northern Ireland. Is that albeit high-level summary of the role?
That's correct, yes.
And then just if I may, in terms of your remit, the 2011 Act defines an older person as normally being aged 60 years or over, is that right?
That's correct, yes.
And that in line with census data from March 2021, Northern Ireland had an over 60s population of approximately some 439,000 and roughly 23% of the population.
Yes, that's correct too.
If we could just then move towards the subject matter of this module, which is the impact of the pandemic on the adult social care sector. And again, you set out in your statement that approximately 60% of the requests for individual assistance to your office relate to health and social care. The highest proportion of issues raised relate to care homes, and that during the pandemic, the government's response dominated your engagement on behalf of older people. Is that correct?
Yes, it is.
If I could pull up, please, on the screen, INQ 237831, and this is taken from a briefing which you prepared in October 2020. And just if we could look at the first bullet point under paragraph 5. In October 2020, you felt it important to emphasise that when considering care homes, we're talking about the homes of around 14,000 older people in Northern Ireland. These settings are their homes. And then again, at the final bullet point there, you state that Northern Ireland needs to stop talking about care homes as buildings and care home residents as numbers. They are our parents and grandparents who remain part of our society. As I say, that was October 2020. Why did you think it was important to emphasise those points at that time?
I think it was important to emphasise that because sometimes we do lose the fact that care homes are people's homes, and that is something that needs to be considered when decisions are being taken that affect care homes, particularly in the instance of a global pandemic. And I think it's really important that at the forefront, when we were talking about older people, we're not seeing them as being placed in a care home for the end of their lives, but actually that is their place where they are entitled to family visits, to live as happy and as fulfilling as life as possible. And I think that, it's important to have had that in the forefront in some of these discussions in relation to actions taken during the pandemic.
Thank you. If I could have up on screen then your witness statement, which is 474926, page 17 in paragraph 56. You state there that the pre-existing structural weaknesses in the system for delivering adult social care in Northern Ireland were horribly exposed at the outset of the pandemic. I'm well aware, and the inquiry is well aware, that you've done an awful lot of work in this area. And perhaps we don't need to delve into the full nature of those pre-existing concerns, but in terms of the impact on the adult social care sector during the pandemic, how did these pre-existing concerns impact?
Well, my office had released a series of reports over many years, both preceding my time as Commissioner and since then, as well as a number of other reports into the health and social care system in Northern Ireland over the last 10 years and beyond, which report after report highlighted some of the key weaknesses in our system, issues around recruitment, staff shortages, terms and conditions of staff, and also linkages between how the health system and the social care system would link up and link together. And I think what COVID exposed in early 2020 was some of these problems that were in the system led to a serious impact, unfortunately, on many of the older people who were living in those homes.
The former health minister, who's quoted quite a bit in this inquiry, described the adult social care sector as the Cinderella service, undervalued and under-recognised. Is that a description which you recognise? Yes, it is. And I think it's worth pointing out as well that sometimes Northern Ireland is held up as an exemplar in discussions within the UK as having an integrated health and social care system. But both myself, my office and many other organisations have for some years now been raising concerns about how those two parts of the system link together and work up. Before we descend perhaps into some specifics of policies or guidance during the pandemic, in terms of a brief overview from your perspective of the impact of the pandemic on older people in receipt of adult social care? Well, it was devastating. Unfortunately, COVID-19, the people at risk were older people and people with underlying health conditions. And that swept through Northern Ireland as it swept through many countries before it reached our shores. Unfortunately, in relation to the likes of care homes, the nature of the virus was just extremely difficult to control once it got into those settings. And the system and the sector was ill-equipped to deal with what COVID brought. And as a result of that, unfortunately, many people lost their lives, and many older people spent the last months of their lives in dreadful circumstances. It also affected the wider social care system, where older people were locked down, where people, reliant on domiciliary care packages became a big problem in many areas as well. So these were all issues that were being brought on a regular basis to my office. And I think it was, devastating is the word, when you look at the loss of life and the experience that many older people and their families had over those few years. But if we could start then a bit of an exploration of what happened in Northern Ireland, and if we could start with what became the 17th of March 2020 guidance entitled COVID-19 Guidance for Nursing and Residential Care Homes in Northern Ireland. And for everyone's note, the final version of that guidance appears at INQ 00120717. I understand that you were invited to attend the meeting on the 16th of March 2020, but it was ultimately attended by your chief executive. Is that correct? That's correct, yes. Prior to that meeting, a draft copy of the guidance was shared with your office, and in your witness statement at paragraph 102, you describe how it was viewed as unrealistic and impractical. I would just like to explore, first of all, is that the view of Cockney, and how was that view formed, that was unrealistic and impractical?
Well, I think whilst we did receive consultation on some of the guidance that was produced in those first 6 months and beyond, the timescale for receiving that guidance was very limited. We believed, as other organisations who were consulted upon, felt that there was very little opportunity to influence the guidance. We saw issues in terms of the implementation of the guidance that we felt needed to be talked through, particularly in terms of the care home sector. And, you know, that meeting that it was held on the 16th of March, I clearly remember my Chief Executive coming back and reporting back to me on some of the concerns within that guidance, but also reporting that the department was very clear that they wanted to issue it the next day.
If I may pick up that point then, the department, you say, were keen to issue it the next day, and this is obviously reported back from your Chief Executive. In your opinion, was there a need to urgently issue guidance to the adult social care sector?
I appreciate that it was an urgent and an emergency situation, and we were looking for quick and decisive action on all of these issues. However, the strong feeling of myself and colleagues and others within other organisations was it would have been better to take more time to consider the real implications of that guidance. There was clearly concerns being raised from the care home sector in particular about the practicality of some of the guidance that was being introduced, and also concerns about from the sector in terms of their resources, about their ability to actually implement the guidance. So in my view, it would have been better to take some more time to try to get the guidance right and also pave the way for its introduction. And I think that would have led to a more effective implementation of it.
I appreciate that you represent older people, you don't represent the care providers, but you've mentioned at least twice there that they flagged issues with implementation. Can you recall at this juncture what the issues they were raising were?
A lot of it was down to resources. You know, there were a lot of new issues that were coming on the scene very quickly as a result of the pandemic. So a huge level of increased, infection control measures, for example, was being asked. How the new arrangements were going to be managed in terms of actually running a care home, how the social distancing was going to be managed. This was also at a time when the homes were raising major concerns around PPE provision as well. So there was real concerns that they were having about their ability to care for their residents as effectively and safely as possible. And that concerned me as the Commissioner for Older People, that I felt that this guidance, whilst it may have looked good on paper, if it wasn't going to be implemented on the ground, then I didn't have much confidence that it was going to be effective in what it was set out to do.
For the avoidance of doubt, I raised with you the draft guidance you viewed as impractical and unrealistic. The final guidance was then issued on the 17th of March. Were those issues addressed for between the draft and the final version?
No, I don't believe so. There was very little, if anything, changed, which was frustrating for both myself, my wider team, and also other organisations.
The first page of the guidance, the final version, states it's been developed in consultation with a number of representative bodies. If the consultation relied on was that meeting on the 16th, does Cockney think that was, or does the Commissioner for Older People think that was sufficient?
No, it clearly wasn't.
I appreciate that you weren't at the meeting on the 16th of March 2020, but you report that your Chief Executive formed the opinion that there was an air of unreality expressed on the part of either officials of the Department of Health or the Public Health Agency, that what was seen on the TVs happening in Italy wouldn't happen in Northern Ireland. Is that a general impression that you picked up during those times in March 2020?
Yes, I have to say it was. We had several conversations raising concerns about care homes. We had seen on the news what had happened in places like Italy and Spain weeks before, and there were some horror stories that had emerged. So I had major concern about, with my limited knowledge of COVID at this stage, I was no expert in it, but it was clear from listening to the experts, that this was a virus that spread widely. It was a virus that was targeting older people particularly. So those conditions alone made me very worried about protecting care homes, and to liaison with the authorities to see what steps could be taken to better protect people. And whilst I appreciate this all came at breakneck speed to the department, I do think more could have been done in consultation to try to get that guidance better and more realistic in terms of its implementation.
You state then, perhaps a more general point, is that at a paragraph 100 of your statement, that there seemed to be a high level of reliance on what was being published in England in relation to the NHS, and I was concerned that insufficient time and opportunity was being provided to consider the implications of its effectiveness when applied to Northern Ireland's very different system. Can I ask you for an example or a specific? How did this reliance on English guidance impact on what was happening in Northern Ireland?
Well, we didn't have the exact same system. As I said, we had albeit an imperfect, integrated health and social care system. So we were different in terms of the setup, the linkages between the NHS and the social care sector. I think there was also a difference in the size and scale of the operation. I think Northern Ireland being a much smaller place, we probably did have opportunities to work together in collaboration more effectively in those early weeks. And in my view, there was a great willingness from the different organisations to do that. And it's just a regret that we didn't have some of those conversations earlier on. And I think if we had the opportunity to feed into that at an earlier stage, we may have got the guidance in place more effectively earlier on as well.
We're talking about guidance at the very outset of the pandemic here, so it's the 16th and 17th of March. Did the picture improve at all over the coming months and years?
I think there was a gradual improvement, but I think there was still a feeling that new plans that were being drafted within the government came to us at a fairly late stage. So when they developed, for example, the Care Partner Scheme later that summer, I still think there could have been more early engagement on the details of that scheme, both with my office, but again with the providers, because there were a lot of concerns raised by them. A lot of care homes were contacting my office at that time, saying that whilst in theory they were in favour of the scheme, they felt that in practice it was going to be very hard to implement, given the lack of resources. So again, I think there would have been an opportunity to feed in and have a more collaborative approach at an earlier stage, because the feeling was that certainly my organisation and others wanted to work constructively with government. As Commissioner, one of my statutory duties was to provide advice to government, and I felt that that could have been taken on board at an earlier stage.
And if I could just delve into then some of the more specifics. In relation to PPE, the 17th of March guidance set out the trusts will continue to work with residential or nursing and residential homes on the provisions of appropriate PPE where they're unable to source their own supplies. So the position was that where private providers couldn't source supplies, they were to go to the trusts. In your opinion, was that an appropriate position?
I don't think it was. In those early stages, it was very clear that the PPE stocks were being held for the hospitals and the NHS. We were inundated with many care homes coming to us in those early weeks who, despite receiving assurances from the Minister and officials in the Department of Health who said homes can go to the trusts and get that equipment, homes were reporting to me that wasn't the case on the ground, that they had been contacting the authorities and getting nowhere in terms of getting PPE stock. So that was a major issue in the early weeks, and it was something that put extra stress on the care homes themselves. Specifically
then, in March 2020, what alternative should or could have been put in place to ensure that providers received the PPE they needed?
Well, some of this was happening really when the hospitals were pretty empty. In those early stages, we didn't get a surge on the NHS for quite a number of weeks. There was a lot of reports back at that stage, of a lot of the facilities not being under any pressure. So I think more could have been done in those earlier stages. I think it was clear that care homes particularly were more vulnerable in those early weeks than the hospitals. The hospitals at that stage seemed to be well stocked, seemed to have plenty of free beds, but the care homes were the ones really in the firing line in those early weeks. And despite the pleas of many homes to get that equipment and through, it did take some time for that to happen, and I think that could have been delivered to them more quickly.
You said it took some time, so the guidance was amended on the 26th of April to ensure that providers would have a buffer stock provided to keep them going. And in a briefing which you provided on October to the Health Committee, which again we've already looked at, you talk about how these issues continued into late April or May. Is it fair to say that the PPE position improved after that change to the guidance and the requirement to provide the buffer stock? Yes, it did gradually improve. I know there were several conversations that both myself and my team had with Department of Health officials, where we went back a couple of times saying that we were still hearing problems on the ground. I know the department agreed to issue a statement again to the trust, reminding them that they should be providing this equipment to the social care sector. But it was clear from what we were hearing on the ground that still took some time. It did improve, but it did take several weeks before we seemed to have that sector being properly supplied. If I may move on then to just briefly discuss the discharge policy, and this was the policy of patients being discharged from hospital without testing in the early months of the pandemic to care homes. And you set out in your statement that concerns were being raised of your office both by families of residents in care homes and by providers, both through the Independent Health and Care Provider Organisation and also individual providers. What concerns were being raised with the Commissioner in, say, March, April 2020? Well, exactly that. There was a number of people had contacted our office directly, and also had contacted the independent healthcare providers, raising concerns about the discharge of older people from hospitals back into care home settings without evidence of that they were tested for COVID-19. Now that raised real alarm bells, both for myself and for a lot of the providers, because there was no way of knowing if that person was positive or negative. And obviously at that stage we knew the vulnerability of care homes, so it was very difficult for them to manage that situation, not knowing if somebody had COVID or not, and what actions they could take. So that was an area of concern. There was family members also contacting my office at the time, raising concerns about that as well. They had been aware that people had been discharged from hospital, and this obviously, in these early stages, this was the time when everyone living in care homes, there was no vaccine, so people were extremely vulnerable, and a lot of care homes were managing the situation as best they could. But they did feel that it was unfair that they were having to take people in without getting that reassurance around the testing of them. And what do you think caused or contributed to this issue where people were being discharged without testing? Well, it seemed to be that the focus on the NHS was there was a major concern that there was going to be a surge in COVID cases to hospitals. It seemed at that time to me that the NHS was trying to clear out as many beds as possible to create space for that expected surge. However, at the time, you would have to question, did all of those people have to be discharged as quickly as that? Or could there have been tests done on more people at those early stages when the NHS wasn't under siege? It would seem to have made sense that there would been extra steps taken to try to prevent unnecessary spread of COVID back into care homes. you say there, did all of those people have to be discharged? I think we're going to come on to visiting shortly, and in the context of visiting, I think you accept that ultimately a visiting restriction was necessary in the early stage of the pandemic. But what if any alternative could there be to this situation which arose regarding testing, especially whenever the Department of Health would say that the capacity was so severely limited that these people couldn't be tested?
Well, I think there was still, it was, I think, a very grey area, the testing in the early stages. It was something that concerned me quite a lot. As I spoke to some of the experts, the virologists, the epidemiologists, to try to get a better understanding of this disease and the implications and how quickly it would spread, it was very clear to me when I asked them in several meetings around, test and trace, whether that should be part of the strategy to try to monitor the virus and control it. And all the experts I spoke to in those early months were very clear that that had to be part of the approach. Now, I think it took a while for testing capability to be ramped up, but there still was some initial testing in those early stages, and I think there could have been more testing done for those people being discharged.
Just for everyone's note, you said it took a while. The version 3 of the interim protocol on testing from the 19th of April, and as reflected in the 26th of April 2020 guidance, basically mandated or required testing prior to discharge. It's your position, however, that intervention or change in policy was too late?
I think it could have been brought in earlier, yes.
A couple of discrete points then around the discharge policy. To what extent do you understand that individual care homes can safely isolate residents who have been discharged?
I think that was a real difficulty for a lot of the care homes. Certainly, many of the care homes that were coming to my office were being very open and honest about their capability. They hadn't dealt with anything like this before, albeit they had the experience of infection control, but not on this scale. So some of these actions, like the discharge, were extremely hard for many of the care homes managers who were trying to manage the situation, an already very difficult situation within the home. And I think the fact that there was people being brought in back from hospital, not being tested at that stage, they struggled to know about what sort of steps and actions they needed to put into place. And I think that was something, again, until we got more of a proper testing programme in place, that continued to be a constant worry for the providers and the families.
And is there anything that can be done in the future, apart from, as you say, perhaps a greater capacity or prioritisation of testing to avoid this situation happening again?
Well, I would like to think that some of the learnings of this will be that we need to be better prepared for a future pandemic. We need to be planning the resources that we have in place. We need to be able to put that in place a lot more quickly than previously. And I accept it was new to everybody, and people didn't know, and a future pandemic could be different. But I think there are basic steps that can be taken and resourced that can at least put you in a better position if you're faced with something like this again. Not just in PPE, but testing, and certainly a better plan to facilitate visiting and human contact with people in those situations.
May I just explore perhaps one of the basic steps then? In that briefing to the Health Committee, you say that it's imperative that any lessons which can be learned from the use of step-down facilities are applied. What lessons could have been learned from the use of step-down facilities in Northern Ireland?
I think the whole the health service can be reviewing all the steps and all the decisions it took at the time, and look at how effective they were. They will know better than me how there are different areas that they put in place, how well utilised they were, how effective they were. But I think for me, it's about putting those resources in place and putting enough emphasis on preparing for a situation like this again. Obviously, we all hope that this doesn't happen again, but a lot of the experts predict it could well happen well within our lifetimes again. So I think there just needs to be more of a focus. I think the COVID-19 pandemic just identified how ill-prepared we were as a society for something like this. And I think, it would be terrible if we didn't learn those lessons and at least put in place an action plan and resources that would allow a swifter response if we're faced with this again.
If we can move on then to the issue of testing, and I appreciate the two are heavily connected. We've perhaps discussed testing policy in March and April. However, you set out in your statement that you issued a briefing on the 4th of June 2020, and your primary focus was to obtain a rollout of a proper testing programme for the adult social care sector. So that's the 4th of June. What was lacking, in your opinion, in terms of testing for adult social care as of the start of June 2020?
It was just the programme of testing didn't go far enough. I thought it was too slow to get up and running. Again, I was no expert in this, but I had several meetings with experts at this stage. I had a very clear picture emerging of how this needed to be tackled. The care home situation by this stage, we knew in the first couple of months just the devastating impact it was having, and all the experts were saying the same thing to me, that testing and tracing the virus was absolutely critical for homes to get a handle on it. So for me, it was far too slow in coming in the first place. In fact, there was several statements made that seemed to say that a testing system in care homes wasn't needed, which was of deep concern to me at the time. And I thought, eventually the department did come up with a testing programme. Initially, I welcomed its introduction, but I also pushed to ramp it up as well, so that the amount of testing happening could be increased as it went along. So I think eventually we got to that stage where there was regular testing. But again, I had deep frustration at the speed of that. And what I saw was maybe a lack of urgency about how important that was in the response to the pandemic.
Northern Ireland reached then August 2020, and the position was that there'd be a rolling programme of testing, with residents to be tested 28 days, staff every 14. Do you consider that that was appropriate?
Again, speaking to experts, it was clear that it wasn't sufficient. It was an improvement. It certainly was something, but it wasn't going to be enough to give the level of protection that I was seeking at the time. I realised that there was limitations on the number of testing. The programme had to be ramped up, and that's what some of the feedback that I was getting. But I was getting clear expert guidance that the testing system should have been testing staff and residents on a more regular basis, and that's what I was pushing for at the time.
Perhaps if we could call up on the screen some correspondence from yourself from the 8th of October to the Minister of Health. If I could have INQ 250250 on the second page, please. And then I think it's the third paragraph. We say, and this is again October, I'm very concerned to see the rising numbers of care homes recording outbreaks in COVID-19 infections. And while this may point to the testing system working, I believe we are now at a stage where testing must be increased to weekly if we are to identify more positive cases before they have time to spread. So in the 8th of October then you're calling for weekly testing, and you feel that's important in order to identify more cases before they spread further?
Yes, that was the case. And again, as I said, that was based on several meetings I had with experts, virologists and epidemiologists, and it was clear their advice to me was that, really the more regular testing programme that you have, the more you can catch the virus at an earlier stage. You can identify outbreaks at an earlier stage, and then hopefully put in measures that can contain those outbreaks. So at that stage, I was very keen that the Minister considered that and introduced that as a matter of priority.
Thank you. Now, In fact, weekly testing of staff was introduced on the 3rd of November 2020, so roughly a month later. What do you consider about the timing of that change? Was it sufficient or appropriate?
Well, I think in all of these, I think we were playing catch up. I think all of these things could have been introduced at an earlier stage with testing. It did feel that for quite a while there was quite a bit of pushback on this, and I just felt that throughout the testing programme it could have been introduced earlier, it could have been ramped up earlier, and that was my frustration. And I think whilst resources may have been one of the issues, I don't believe it was entirely about resources. I think in the early stages there was certainly there didn't seem to be a huge appetite for testing, and particularly in care home settings. So I think that set everything back, and I think all of this rolling out of the testing system could have been done weeks earlier.
As you say, we're primarily discussing care home settings, but that same correspondence goes on, please. If we have a look at the final paragraph. I've also raised a few officials on a number of occasions about the need for domiciliary care workers, home care workers, to be included in the regular programme of testing. It's not reasonable to expect these workers to go and arrange tests for themselves in the same way as a member of the public does. Was there any meaningful engagement from the Department of Health on your suggestion that domiciliary care workers required testing?
Again, I think this was an area that was behind the care homes, I think, in terms of being looked at. I think it's fair to say we were still receiving some concerns raised from family members and older people about domiciliary care workers not being tested, but not on the same scale as the care home setting, because I think the feeling was that the risk was less in those settings, whereas just the nature of a care home and the number of people living under one roof, that the focus was on trying to ramp the testing up under that, because they felt it seemed like they were under a much higher level of risk. However, we had conversations, and obviously that letter was raising the issue about ramping up the number of domiciliary care workers to be tested as well, because the concern there as well was obviously these care workers were going into many different people's houses on a daily basis. So anyone who was positive for COVID was at danger of exposing quite a number of older people to that if that hadn't been picked up in a testing regime. So again, yes, it seemed to come after, it seemed to be further down the line in terms of urgency, but it was certainly an issue of concern.
While the intricacies of exactly when testing for domiciliary care workers can perhaps be worked through with other witnesses, it would appear that it was not until at least early 2021 when tests were available, and perhaps even as late as August 2021, until regular testing was extended to all independent providers of domiciliary care. In your opinion, what was the impact of that not being introduced until 2021?
Again, I mean, it's obvious that COVID was widespread in the community. You were always going to have some of those domiciliary care workers who would have been infected, and the lack of testing for them means that wasn't identified. Particularly with the nature of COVID, if somebody had some obvious symptoms, that was one thing, they could take action. But the nature of this virus obviously was that you could have no symptoms at all and still be positive. So that was certainly a risk to the people that they were going to visit every day. And the longer it took to introduce that testing, the more people were exposed to that risk.
If I may move on to the issue of visiting of residents' care homes, and I did allude to this a couple of moments ago, but I believe it's your position that at the outset in March 2020, there was a need for some form of visiting restrictions in care homes. Is that correct? And can you explain why you think that?
That was correct. I took a position at the time. It was a very difficult decision, one of the most difficult decisions, I have to say, throughout the pandemic. And there was no good decision to take here. It was clear from the outset that, I was aware of the impact that this was going to have on people. but at that stage, it seemed like the right people's right to protect their lives trumped everything else. So at that stage, it was seen as the best way to protect people's lives was to create what was called a ring of steel. That it was that we restricted access to the care homes as much as possible. The experts had advised me, the less people going in and out from the community, the less risk for people in those care home settings. So, certainly in the early stages, I supported that policy. I think over a period of time, I realised that the negative side of that policy was very serious and probably more serious than we initially expected. I think also the other reasoning behind taking that approach in the early stages was we didn't know how long this was going to take. We didn't know how the virus was going to continue at that early stage, so we didn't know how long we were in a position of lockdowns like this. But clearly, by the mid to late summer, the level of concern raised by families to my office was really significant, and the stories that we were hearing about individuals and the decline and deterioration of older people in those settings was very distressing. And I think that certainly this is one of the areas that I think the learnings from this inquiry can actually put into place really concrete changes to how care homes could cope with this in future, because it was clear to me that for many older people that system meant that they didn't see family members face to face for the last weeks or months of their lives. It was a very awful position to be in, and I think in the future we need to weigh up the risk associated with contracting the virus and putting in place measures that allows continued social contact and direct human contact with family members.
If I may then just actually turn to what you say, the kind of concrete changes or recommendations which you think could be made here. Paragraph 117 of your statement, you say in the future decisions will have to be taken for cohorting those older residents of care homes who choose to live with the risk of infection, with all the potential tragic corollaries, but who value daily contact with loved ones above the risk of their longevity, and conversely providing more rigidly isolated care homes for those whose preferences protect themselves. If you just expand on that, are you proposing, in effect, more resident choice going forward in how this would all apply to them?
Yes, I am. I think from reflecting on this issue particularly over the last few years, I think measures need to be introduced into care home contracts that make care homes have whatever you want to call them, isolation rooms, visiting pods, but some sort of physical capacity to enable face-to-face visiting that reduces the chances of wider infection. I believe something could be done on that front. At the time, the Minister announced some funding that homes could look into visiting pods, and I know some homes took that up, and I think the homes that did take it up, it worked quite well. And I actually think this is actually a really key issue going forward, because what the visiting raised has raised real fears amongst older people and people of all ages, I suppose, who are looking into the future and thinking, if that was me, by far the most people I speak to say they would want to still see their family and have human contact, even if it exposed them to greater risk. And I think something that changed the contract, put the resources into providing that within the care home setting. So if we're in this situation before, that we don't have to have a total lockdown of visits, I believe that social contact is just too important to lose. And I think speaking to a lot of the families who came to the office, and I've the families of the bereaved, I think that was a cruel end to their loved ones' lives, and I actually think there's putting steps in place like that would be really important for people's end of life. and also for people going into homes in the future. I think we need to get increased public confidence and trust that people wouldn't be faced with that situation again.
You've mentioned two issues there, the first being a resource issue, the second then being some type of protection for residents' rights. I'm curious, you mentioned twice there that the care home contract you see would be the way to do that. In England, regulations which the regulator enforce have been changed to guarantee visiting. And in Scotland, there's legislation working its way through the Scottish Parliament in Anne's Law. Do you consider that it's the care home contract, it's that level at which intervention needs to be made, or is it a more legislative or regulative change?
Well, I think, I wouldn't have a firm position on that, and I think, Northern Ireland should look at what's happened in other jurisdictions. The key for me would be that the system is put in place is effective, and whether you need legislation to do that or whether the contracts can cover that. But I do think we need a situation where the care homes must provide that facility. And that's up for government to look at the best way to do that. I think if you had that in place, you would also address other issues that came up, not just the visiting, but also access, for example, GP access to care homes that was cut out, and also access for the likes of the RQA in Northern Ireland, the inspection regime. I think it would provide a lot more support for homes if you had that facility.
Before moving on to RQA and care partners, do you believe that decision makers understood the crucial role that family carers play in care settings for their residents and loved ones in care homes?
I think that became more clear after a few months of the pandemic. I think the Public Health Agency started to have regular meetings with family members, and I think most of the authorities got that restriction in visiting was having a huge detrimental impact on the residents. So I do think people realised, when they listened to the stories, when they listened to the impact on families and older people, I think most, if all of the authorities realised that this was an issue that needed to be looked at, and obviously the care partner scheme emerged from those discussions.
If we could then move on to care partners, I'm going to refer back to the 8th of October correspondence you sent to the Minister. If I could have that back up on screen, please, INQ 250250. Just at the bottom then of that page. You say that your office has spent the past 4 weeks dealing with calls from families in distress and then angry when care providers could not deliver the access to their loved ones, which they believed the new guidance entitled them to. And then also that home providers are stating that they are not able to safely facilitate the visiting arrangements outlined in the most recent guidance. For the avoidance of doubt, this correspondence in these paragraphs, is that dealing with the care partner concept in particular?
Yes, that's correct, yeah.
And in your statement, you say that you observed tensions between family members who wish to have access and care providers who were struggling to implement the concept. What, in your opinion, was the source or the cause of that tension?
Yeah, this was a really big issue at the time. We were getting really mixed messages after the announcement of the care partner scheme. Some of the providers seemed to adapt well to it and put in measures that made it possible to introduce it. There was clearly some providers who wanted to do it, but were saying that they had a lack of resources to implement it, and had some difficulties implementing parts of it. And then at the other extreme, we came across providers who just seemed to not adopt it at all. And we had families coming to us who had heard about the care partner scheme, had heard, friends and relatives with people in other care homes getting access, and yet the care home that their loved one was in wasn't providing this. So there was a clear inconsistency of approach across the sector. I think part of it was communication. It seemed to be that there was confusion from some of the providers that we dealt with directly, who didn't seem to think that they had to introduce this scheme. And I'm not sure where that confusion came from, because they all should have received the same guidance. but there definitely was a different approach from many of the homes. Some of it was about resource, but some of it, I think, was about the understanding of what they were required to do.
You talk about issues of confusion, and we're trying to perhaps delve into where that arose. Do you think whenever you look at the communications from the Department of Health to the providers and the families, do you think the concept itself was sufficiently defined?
I think it was. I think it was confusing. It was a new concept, and it was something that, had been brought together quite quickly. In fairness, in relation to the response of families, again, it is probably an issue and a concept that probably needed a bit more time to be talked through on a practical level. I think most people were in favour of what the care partner scheme was designed to do, but again, some of the detail of it wasn't very clear, and there was clearly some of the providers who struggled with introducing it more than others. And part of that was resource, part of it was staff, sickness. A lot of staff at this time were contracting COVID, and there was a lot of issues around that. So there was extra work involved for the homes to implement the scheme, and I think some of them were just had the ability to do that more quickly than others.
In terms of talking this concept through, about a week or so before your correspondence, Miss Shepherd of the IHCP wrote to the Chief Nursing Officer, flagging that there had been no prior engagement with providers in the care partner concept. Do you understand that there had been no engagement with the IHCP on the care partner concept?
Well, I can't say for sure, but I know at that stage that we had been in regular contact with Pauline Shepherd right throughout this, and there was a frustration on our side, that the lessons hadn't been learned from the previous experience of developing guidance and consultation. So when we look back on what happened in March, again, there was a feeling that there should have been, a more collaborative approach to this. And again, that, in my view, led to the difficulties in implementing the new policy consistently across the sector.
You used the word "our frustrations" there. So was the Commissioner of Older People consulted or engaged with prior to the announcement of the care partner concept? There was consultation with us on it. Again, we were aware it was being developed. I think it had come from memory. It had come out of a lot of the meetings with the Public Health Agency, so we were aware that this concept was being worked on. Again, from the Commissioner's point of view, we probably weren't the experts in terms of identifying what was going to work and what wasn't, and that was probably something that did require more engagement with the sector as well. In terms of looking at the practical implication of this. So whilst we would have had our views on it, and my view at the time was broadly supportive of the concept, I didn't think it was perfect, but it certainly it looked to me like a significant positive move by the department at the time. And does that continue to be your opinion today? Yeah,
I think it was a positive development, but I think it's something that, if we were planning again for what we would do in a pandemic situation, I don't think that would be the perfect solution. I think it was quickly pulled together. It certainly helped some families. It gained access for many families. But I think it's really important going forward that we look in the round, that it's not, I think a new policy needs to look not just at the sort of care partner type system, but also just the wider general visiting as well in homes, as well as looking at GP access and inspections as well.
I think there's a general acceptance that we're going to always fall short of the perfect solution for every scenario, but you're accepting that the care partner concept is a positive one. It just perhaps needs more work to work through the practical implications.
Yes.
Robin Swan, the former Health Minister, in his written evidence to this module, suggests that the concept should be placed on a statutory footing. What, if any, benefit do you think that would have?
Well, again, I think it could have benefit if it was a revised version of it. I think we would have, part of that process, it should be reviewing how it actually worked in practice. Also, any review of that would have to identify what resources would need to be put in place from a sector point of view to implement it. I think the idea is good. I think the idea that family members should have more of a say in the care of their relative is a very positive thing, and it should be facilitated as much as possible. So again, I wouldn't say that the care partner scheme that was introduced in 2020 would be just the scheme that you put in 2025, but it certainly would form the basis of reviewing what was needed, and I think it could be built on and made better.
Thank you. I'm going to turn briefly to RQIA and inspections, and your position set out pretty clearly in your witness statement at paragraphs 149 and 150 that you think a degree of, or inspections should have continued to a greater degree than they were. And if I could just ask you about the services support team, which was the reorganisation which took place to enable inspectors to support care providers during the early weeks and months of the pandemic in particular. First of all, do you consider that that was a helpful step which was taken by RQIA? And secondly, do you consider that it was in any way an adequate substitute for the oversight or assurance provided by inspections?
I think, again, this was quite a difficult one. I think at the time, this decision was taken at the time when we were about reducing footfall in care home settings. So there was some rationale for stopping physical inspections with that in mind. However, reflecting back on it, I had concerns at the time about what that would actually mean if there was no oversight of the services happening at a real critical period. That raised concerns with me. Probably the bigger concern, based on my experience as Commissioner in dealing with care homes and investigations, my biggest concern was probably the fact that, without friends and family in visiting, I certainly felt I'd lost my eyes and ears on the ground, because to me that was a more valuable source of information than RQIA inspections that maybe only happen once a year. So whilst the inspection stopping, I think maybe in the public's eye probably was a more worrying thing, I actually think the bigger thing was the fact that families weren't allowed in, and I think that was a much more probably a much more damaging decision than the inspections. I think the support services, in theory, again, was a good thing that RQIA would move to this sort of support mode for homes, and I think that was a good thing. But I think also with reflection, I think it would have been better if homes had the facility to bring in inspectors as well. Maybe not from an inspection point of view, but more again as a support point of view, because this was new ground for them as well. And I think if they had a bit more expertise on the ground, that might have helped homes get up to speed more quickly.
If I may just then move on to the issue of DNA CPR notices. You made a series of statements during the course of the pandemic. It's not necessary to call them up on the screen, but it was the 30th of March 2020, the 6th of April 2020, and then again further, even as late as November 2020. Why did you think it was necessary to make a statement even as late as November 2020 in this issue? Again,
this was an issue that kept raising its head every so often. There was people who had come to my office raising concerns about maybe their own family member. There was family members that were discovering that a DNA CPR had been put in place without consultation with them, and worried that the resident didn't have capacity to agree to that. So we were getting ad hoc examples like that. We also, at the time, I was working very closely with the Welsh Commissioner and a series of organisations across the UK. We were having Friday meetings to discuss common issues, and this came up as a wider issue across the UK, where there was a number of stories that had broken, where certain trusts and GP surgeries were writing out to people with underlying conditions and asking them to sign that, and it was seen as not good practice that there was this kind of blanket approach to people who might have been in that position. And in terms then of these statements you make, 30th of March, just to name a few, 30th of March, 6th of April, and then into November, what, if any, response did you receive from the Department of Health to those statements? From memory, there was this came up in a few of the meetings we had with the Department of Health. We raised it as an issue. We got assurances that this is something that shouldn't be in place. There was agreement that the process around DNA CPR shouldn't change. So again, I think the outcome of that was really, again, communicating that we were, keen that it was being communicated at across the health service, whether it was a trust level or GP level. But as organisations, we felt it important to put it out there because there was a genuine concern amongst older people at the time that they may not be admitted to hospital as well. And this was, again, a concern for care home providers as well about whether they should, ring an ambulance for somebody if they're in this position. And
very briefly, are you satisfied that there was sufficient then communication from the Department of Health across the sector in order to deal with those concerns?
I think communication did go out, but I think the fact that you've referenced, some of those statements over a period of time reflects the fact that we were still hearing some cases where people were surprised to see this in place. So I think, again, the communication got better, but there was still some experience where families were bringing to my office saying they were surprised to find out this was in place, because, again, it'd be something that should involve the family.
And just in finishing then, 2 final points. You create the impression that there wasn't sufficient learning from first to second waves of the pandemic. Is that a fair summary?
In terms of DNA CPR?
In terms of a whole heap of issues affecting the adult social care sector? Yeah,
I think it could have been better. It could have been better. I think there was a lot of learning early on. I think I went and gave evidence to the Health Committee, who did a review of the response to the pandemic in, I think it was August 2020, September. And even at that stage, I felt there was learnings from the first few months. So I think by the time we were in the next wave, I felt we could have learned more and be better prepared.
And just very finally then, your kind of global or ultimate recommendation coming out of all of your experiences is that future and planning must be informed, if not created by a group of experts, by experience, including private care home providers, their operational staff, and family members of care home residents. Just in terms, practically, how would a group of that nature work, and how would it have improved the response of the adult social care sector?
Well, again, as I said, I do believe there was a lot of commitment from a lot of organisations and members of the public who wanted to feed into these very difficult discussions and decisions. And I think in the future you would want to see more of a commitment from government to press the button on starting up a group like this. If we were faced with another pandemic, that this group would spring into action pretty quickly, working collaboratively with government. And I think if it did do that, you'd probably get to the stage where you could get guidance, better guidance more quickly. In terms of the practical implications, none of us have a crystal ball about when the next pandemic hits. So obviously, from a practical point of view, that would be something the government would need to keep updated on an ongoing basis to know. But I do think it would be valuable to have a group of experts, because I was surprised even 3 or 4 months in, when I had some of my meetings with experts, about how little they had been called on from government in terms of decisions, and I felt that was a serious gap.
Thank you very much, Mr. Lynch. Thank you, Milady.
Thank you, Mr. Beach. Now it's Mr. Wilcock, who's just sitting there.
Good afternoon.
Good afternoon.
I am asking you questions on behalf of the Northern Ireland COVID-bereaved Families for Justice, and I'm going to I've been given permission to ask you questions on 4 topics. The first topic is the one you've just been dealing with, DNA CPR. And I want to ask you about a question that the Minister of Health was asked by a fellow MLA in March 2021 about the application of DNA CPRs in Northern Ireland. And the written question that he was asked was this: how many audits have been undertaken to monitor adherence to policies and guidance in relation to do not resuscitate orders in respect of people with 1, learning disabilities, and 2, dementia, who have died with COVID-19? And Mr. Swan's answer as he's explained to the inquiry Module 3, was this. He wanted to make it clear that orders based on age or disability were discriminatory and unethical. And he further asserted, in terms of the policy in Northern Ireland, media reports about the application of DNA CPRs were ill-founded. But he was unaware at this time whether his department had ever considered or conducted an investigation into the concerns that were raised about inappropriate use of DNA CPRs. First question, did the Department of Health or any other agency in Northern Ireland proactively contact Company in an effort to understand the depth and breadth of concerns about the use of DNA CPR in the north of Ireland?
I don't believe there was any specific request for meetings to discuss that. I believe this issue came up in several meetings that I had throughout the course of the pandemic with officials, where that issue was one of a number of issues that we had raised with the department, but I don't recall any specific meetings being requested from the department to us.
Thank you very much. And presumably in those meetings you told them what you've told us in your statements, etc.
Yes.
Are you aware of any internal or independent audit that would have been sufficient, carried out by any agency, to answer the MLA's questions, particularly with respect to those with learning disabilities or dementia in Northern Ireland?
No, I'm not aware of any audit.
Did you have any sense that the department or any other agency was taking the concerns that you were mentioning in the meetings that you've told us about, that were being publicised in the media about DNA CPRs in the year following, between March 2020 and let's say March 2021, did you think the department was taking those concerns with the appropriate degree of seriousness?
I think whilst these issues were raised in meetings with the department, I think it's fair to say that the majority of the time that I had to go out in the media and speak on these issues is because I wasn't convinced that they were all being fully taken on board. It's certainly with the DNA CPR, when I did the joint statement with other organisations across the UK, the feeling was, I suppose we all were getting similar assurances, but we felt it was really important to raise that publicly and put it out there in the public interest that this shouldn't be happening. Just one other point that I would make, I was particularly concerned in Northern Ireland because we were the only part of the UK and Ireland that still doesn't have age discrimination legislation in place in relation to goods, facilities and services. So I felt that we were even at more risk with some of this. So whilst there was concerns from me and others that there was maybe ageist elements to decisions being taken, I was conscious as well that we didn't have the legal protection that other jurisdictions had as well.
Understood. Second topic, which I can take relatively swiftly, RQIA. We know that in March 2020 a decision was taken to reduce the frequency of statutory inspections in care homes and to cease all non-statutory inspections. Paragraph 149 of your statement, you indicate that there was no public announcement that physical inspections had in fact ceased. Do you think there should have been such an announcement, and if so, why?
Yeah, I think from transparency, I think it should have been publicly announced. As I say, it was, I can't remember the exact time that I found out that they were completely stopped, and then it's, had some discussions with the RQIA on that. But I think in these situations, it's, public trust is really important, and I do believe when decisions like that are taken, that any public authority tells the public and explains the reason and rationale behind the decision.
And you've explained to us when answering questions from Mr. Beach that, in short, you feel that a consequence of this decision was that you, in particular, and every other agency looking at care homes lost their eyes and ears as a result of this decision. Now, in his evidence to Module M2C in Belfast, May last year, the Chief Medical Officer told the inquiry that because RQIA staff were being, in his words, proactive in telephoning care providers to check in with them, then this by itself provided eyes and ears from the RQIA on the ground. Do you think that that did provide sufficient compensation for the loss that you've described?
Again, I don't think so. I think the inspection regime stopping going in was one thing, but I think maybe a lot of the public would maybe not appreciate that that doesn't happen very often. And again, the biggest concern for me was probably family not getting access to the home. I think certainly the support services were a welcome development, but I think looking back, you would still have wanted some sort of physical presence for inspectors to go in that circumstance, particularly under the strain that the providers were under. So yes, I think that would have been a concern.
Understood. Thank you. Third topic, the evolution of care partner guidance. Again, a topic that you've covered broadly already. But in her statement and evidence to this inquiry, Module 3, the Chief Nursing Officer of Northern Ireland, Charlotte McCardle, told the inquiry that Northern Ireland, quote, led the way in ensuring restrictions were applied in a person-centred way. And she pointed in particular to the evolution and implementation of the care partner guidance as an example. Now, you showed us some of the correspondence you had when dealing with the care partner scheme when answering questions from Mr. Beach, and you told us about the tensions you had observed between families and care providers during that process. Did you think that you were witnessing a world-leading example of person-centred care when your offices were receiving phone calls from anxious families and care homes about the implementation of this scheme?
Well, clearly the scheme was inconsistent, was operating at many different levels across different care homes. Some care homes, the scheme worked well, but clearly there was a lot of care homes that were struggling with the implementation of it. And then at the other end of the spectrum, there was homes that just weren't implementing it. So whilst it was progress on the issue, it was far from being a very effective option.
Thank you. Final topic. And this is about the role you played. And I want to give you an opportunity to comment on some of the concerns that families I represent have raised as to the role your office played during the pandemic. And to be frank, some families have expressed concern and indeed criticism that Copney was not sufficiently effective in advocating for older people's needs and rights prior to and during the pandemic, and indeed since. They consider that there was a lack of visibility on the part of Copney. You've told us about the efforts you did make to get publicity, and the slow pace of change, particularly in relation to adult safeguarding legislation, which you've spoken about as well, and the lack of protections against age discrimination. Can you see why some people hold that view?
Well, I think in terms of our activity, myself and my team during the pandemic, looking back on it, I don't believe we could have worked any harder than we did on the issues. We were working very long days and linking up with ministers and officials in a very difficult situation. I think it's fair to say that we weren't experts on a pandemic, so we were learning and having to learn very quickly of the issues we were dealing with. This was all new to us as well. But I can assure you that we were, certainly with the resources we have, and our company is quite a small organisation, that we were using all of our resources to try to influence where we could. But it was clearly a very difficult and challenging time. There's no doubt about that. What I would say is, post-pandemic as well, that there's been a lot of people who have raised personally with myself, older people saying that many older people who had actually campaigned for a commissioner many years ago were actually appreciative that there was a commissioner in place at that time, and it actually highlighted one of the reasons that they had campaigned for that. And I think what it proved to me, it was far from perfect and the responses were far from perfect, but I was able to get access to the likes of the Health Minister on a regular basis, to senior officials, and have some influence in there. I would have liked to have seen things move a lot quicker, as I've given in my other evidence. I definitely think there's a lot of learning there for the future, and I hope that this inquiry teases that out and actually puts in place real strong recommendations that can actually bring about a situation that if we face this awful situation again, that everyone will be in a better position to take action more quickly.
And I have no doubt my clients agree with those sentiments. And I want to make clear, because I'm sure you've already noticed, I deliberately didn't say that the views I've given are universally held, but they are held by some. Thank you.
Thank you.
Thank you very much, Mr Wilcock. Ms Jones, who's over there? Just a couple more questions.
Thank you, my lady. Mr Lynch, I asked questions on behalf of John's campaign, Care Rights UK and the Patients Association. I want to start by asking you about the suspension of inspections by RQIA. The decision to suspend inspections arose, as you say, from a desire to reduce footfall in care settings and the risk that was thought to be associated with that. But in your experience, did that decision take account of the risks on the opposite side at all? So the risks arising from suspending inspections, such as an increased risk of abuse or neglect or of a general deterioration in care. Was that something that was taken into account before inspections were suspended?
As I've said, I think at the time the decision was taken, the focus was on protecting life and protecting the spread of the virus in the very early stages. But as I've said, I think that over the course of time in those opening months, it became increasingly clear about the negative side of not having access for family members into homes as well. So I think for me, this is one of the key learnings in terms of what really would be done differently next time around if we were in this situation. I think it has illustrated just how important that family contact and social contact is with people living in those settings, and the damage as a result of removing those eyes and ears on the ground. As I said previously as well, the removal of on-the-ground inspections, again, is something that I think the public probably would like to see in future continue. But for me, getting family members to be still able to access their loved ones face-to-face is probably the bigger issue here, and giving reassurances to families, to the Commissioner's Office in future, and for other charities that represent older people.
Thank you. Just on the role of families, so not only in terms of the importance of access of family members for the well-being and care provided to people who live in care homes, but also in terms of the monitoring and oversight role that they play. Can I ask, do you think that was something that was properly recognised and taken into account when RQIA inspections were suspended?
I certainly think, in my experience in the post as Commissioner, the role and the intelligence from family members is absolutely critical in ensuring that the care home sector has the monitoring in place to ensure good quality care. And I think, based on my previous experience investigating a care home in Northern Ireland and the report that came out of that, the Home Truths report, it was really clear to me that that was probably the single biggest issue, that family members are so important in ensuring that care is at a high quality, and that when they have concerns about that they're listened to and acted upon. And I think that is absolutely fundamental. And I think going forward, certainly we need to restore public trust that authorities will take the appropriate action if we're faced with this circumstance again.
I hear your recognition of how important those things are. In your experience during the pandemic, were they recognised to be important by decision makers?
Well, I think decision makers did recognise the importance of contact and family. And that was clearly in the conversation at the start. I don't think there was people didn't see that as a big issue, but I think, as I said before, there was no good decision here. At the time, we had deep concerns just about the scale and impact that COVID-19 would have in care home settings. It was frightening, some of the conversations that were being had at that stage, and I think everyone knew that there was consequences for restricting access, whether it was inspectors or family. But I think at that time the primary thing was to save life and to take decisions to try to protect life, and that was really the basis of it.
Thank you. And then my final question's on a slightly different point. At paragraph 178 of your witness statement, where you set out the recommendations that you would make, you say that future planning must be informed, if not created by, a group of experts by experience, including private care home providers, their operational staff, and family members of care home residents. You don't include in that list care home residents themselves, and I just wonder if you think that work should include people who live in care homes and who can bring their own experiences to bear on what preparation and planning should be undertaken.
That's a good point, and I would of course include care home residents in that, and I'd probably go further and say, you probably want to include older people who aren't care home residents currently, because I think it's really important to get the views of people who may be future users of those services as well. We need to have a clear understanding of what people want. It's back to the point about care homes being people's homes, and that we need to protect that. We need to protect the privacy, the family life, and all of those wider things, as well as their health and social care needs.
Thank you very much. Those are all my questions.
Thank you, Ms Jones. That completes the questions we have for you. Thank you very much indeed, Mr Lynch, for the help you've given to the inquiry. Extremely grateful to you. I think this is probably the last time we're going to call upon you, so the burden is over. I don't know if you still live in Northern Ireland, but if you do, safe journey home.
Thank you, my lady.
Thank you. 10 o'clock tomorrow.